Next question. Our question asker says, I am interested in the topic of viremic controllers. Specifically, are there people who remain viremic controllers for long periods, such as 10 or 20 years, or is viremic control a transitory status? Dr. McGillis?
So I think that's, again, when you're talking about a large group of people, there's going to be exceptions to the rule, but for the majority, we have a group of about 15 of these patients now that we've been following, and I can tell you a majority of those people are people whose viral load, their viral set point is a couple of logs higher than patients who have, maintained viral loads less than 50 copies, and their CD4s are pretty decent. There is a very gradual decline, so a gradual negative slope if you track their CD4s over time, and they've been doing, we have 5 or 6 that I can think of that have been infected for 20 years, doing well, and so if you look at the trajectory of the CD4 decline, you could say, well, that's not going to last forever, but in our experience, we're not seeing. There are some patients. The flip side, there are some patients who have had some degree of progression over time, and 1 or 2 have gone on therapy. So it's hard to put a handle on as far as if you looked at a larger group of those patients, what statements would you make about the eventual outcome, the rate of their disease progression. Dr. Levy pointed out how this is kind of a Gaussian distribution, and there are probably people at the very far end of that tail, and then we tend to think of the viremic controllers being maybe a little bit more towards the middle, the mean, median, and mode of that, and there's some variability even within that subset. So I think that's what.
Yeah, I'll just agree entirely. I don't have the same cohort that Stephen has or Peter, but I've seen the viral loads, and we're talking 20 years, since we've been measuring, not that long, but people's CD4s maintaining themselves, and it's remarkable. It just says, in fact, you talk about blips, my own impression is if you have a few blips, you keep control of the virus. We have certainly found that if there are people who have absolutely no anti-HIV response in the cellular compartment, and we would predict if we could get them into a study or they're followed for a week and their viral loads are measured on an hourly or 6-hour basis, you'd see blips occurring. No blips occurring, excuse me. But there are some people who have such incredible control that you can maintain it for a while, but those that allow a little bit of a blip, you will reactivate that immune system, not in a negative way, and maintain, what we measure are CD8 suppressing activity.
That's interesting in our mucosal studies, too. Often it's the viremic controllers who have the higher magnitude mucosal CD4 and CD8 responses, higher in magnitude than the elite controllers who have the. So it may be sort of this Goldilocks hypothesis, I think, that Mike McCune was talking about a few years ago, that a little bit of virus may be a good thing in order to stimulate the immune system. But then, of course, there's a trade-off because you also get immune activation and bad things happening as well. So it's a trade-off.
I can also, we've looked at elite controllers with ultrasensitive assays longitudinally, and of about 90 of them, I think all except 2 had small blips that were still much, much below 50, but only 2 of them stayed below the level, longitudinally below the level of the ultrasensitive assay, which is 0.2 copies per ml. All the rest had small blips, mostly in the range of 10 to 20 copies per ml, but still below the standard clinical assay. So definitely that is occurring to some extent over time.
Another impression, just something that we talk about in our lab a lot, that within the patients that we've been looking at, we tend to see, I alluded to this in the talk, that the patients within this group of viremic controllers or slow progressors, we do tend to see a mixed bag, talk about a Goldilocks effect with respect to their control mechanisms. When we look for broadly cross-neutralizing antibody activity, a good number of them, not all of them, but a good number of them have that. They have some degree of CD8-positive T-cell proliferation that's somewhat intermediate between patients with high viral loads and patients who maintain, much lower levels of viremia over time. We've looked at some other factors too. These are unpublished observations and they haven't been rigorously statistically analyzed. My gut sense is there's definitely much more of a bunch of things going on in this group, some of which is driven by lowish amounts of virus. And I think that even what we're seeing in non-progressors, that maybe some of that is some defect that's not present there, that was never present there, was probably induced early on, that is maintained, and it probably is responsible for controlling it for a long period of time.
It's an interesting subject because I hear from more and more viremic and actually slow progressors as well as the months pass. Thanks for all that. Last question. What have we learned from recent research on controllers that may be relevant for the treatment of non-controllers? Excuse me. How can controllers be identified during acute infection? What are the effects of immune activation on controllers? Now, the last part was probably is redundant to the. So, again, what have we learned from recent research on controllers that may be relevant for the treatment of non-controllers? That's the question.
Well, I'll just say that, as I showed in that one slide, at least in our acute infection study, those people who arrived with high numbers of plasmacytoid dendritic cells, which, by the way, are very low. I mean, the average positive is 2 to 4 cells per microliter versus 600 to 1200 CD4s. But they're very powerful antiviral cells. And if they had high numbers, they had low viral loads. And these people, as I mentioned, didn't take therapy, and we've been following them 2 years, and they're still very healthy. I think they will go on to be long-term survivors. Now, where do I get that? Well, if you work in a research lab and you have a number of people working with you, you sort of ask for volunteers. So we had 17, and that time I had a pretty good lab, but 17 people donate blood, and we had normal PDC numbers ranging from 3 to 17. So imagine then a person has 16, 17 PDC circulating in the blood, and HIV enters. That person may have a much better way of controlling, and then will go on to be a long-term, because it's the early stages after infection, I think, sets the course of whether you'll be a long-term survivor or not. Now, there's all the genetic aspects and everything else, but if you're looking at a biologic event, I think that's certainly one of them.
In terms of the question as to how the research and elite controllers can provide insights for the management of non-controllers, I would say that we have, in some of our elite controllers who have progressed despite undetectable viremia, one in particular with who had Kaposi's sarcoma. You know, we've followed this patient for over 2 years now during antiretroviral therapy, and one interesting thing that we've seen is that while markers of inflammation really come down despite an undetectable viral load at baseline, you go on therapy, inflammation goes down. T cells in this patient didn't really go up very much. In fact, they trended downward, and the patient's Kaposi's sarcoma continued to recur. And we've looked at other markers of immune function in this individual, and markers generally associated with immune senescence and accelerated aging were actually high at baseline and unchanged during antiretroviral therapy. And we think this may give us some clues into the when to start antiretroviral therapy question for typical progressors, that if you wait too long, there may be some irreversible damage to the immune system from chronic inflammation over time. So I think that's one insight that this is just one anecdote, one story, but we think it's suggesting an important biologic concept to us.
I think the answer to that question is that there needs to be more research and more support for immune-based therapies. We essentially have none. IL-2, which the NIH pioneered, was used, was not very good. I think it still is good in acute infection. That's the only one. And companies do not want to develop them. And you're looking at the group here that's studying immune-based observations, and yet there's no one who wants to venture into the immune system. Maybe my slide of the cytokines tells you why, because when you talk to companies, it's much too complex for us to approach it. But that's what we need to do, and I certainly spend a lot of time advocating support for immune studies that will lead to a natural approach to HIV infection, not these toxic antiviral drugs. And we don't see it happen.
I can tell you from an experienced advocacy point of view, there's a lot more requests for IBT, immune-based therapies, and I'm one of them. So there's a swell of interest that's happening out there.